So a very good morning to everyone. I, Dr. Poonam Joshi, welcome you all once again to our Head and Neck ACTREC academic classes. As today's speaker is Dr. Anuj Kumar. Dr. Anuj is Assistant Professor in Department of Radiation Oncology at Tata Memorial Center, ACTREC, Navi Mumbai. And he will be speaking on the topic role of brachytherapy in the management of head neck cancers. So we welcome you, Dr. Anuj. Please go ahead with your presentation.
Thank you, ma'am. Thank you for that introduction. Uh, is my slide visible?
Yes, Anuj, it is visible.
Okay. And is it moving?
Yes, it is moving.
Okay. So, good morning, everyone. I will be talking about role of brachytherapy in management of head and neck cancers. Brachytherapy, the term was coined by the Swedish radiologist Gustaf Forsell in the early 20th century. The word brachytherapy was derived from the Greek word brachys, which means short, referring to the short distance between the radiation source and the target tissue. So, what is the difference between brachytherapy and external beam radiation therapy? So, in brachytherapy, the radiation source is placed internally. That is why we call it as internal radiation. And in external beam radiation therapy, it is delivered from outside the body. The precision is quite high in brachytherapy because we place the radioactive sources directly in contact with the tumor tissue. And in EBRT also, we have a high precision. Treatment duration is shorter in brachytherapy depending upon the type of technique that we use there. And in EBRT, it is longer. When we talk about invasiveness, brachytherapy, as we know, is an invasive procedure and it requires expertise, and EBRT is non-invasive. In brachy, there are more localized side effects and fewer overall side effects to the other organ at risks away from the tumor tissue. And brachytherapy is also a very feasible option in re-radiation setting due to the decrease in doses that we can deliver to the organs at risk. So let's see some of the key events in the history of brachytherapy. In 1898, Marie and Pierre Curie discover radium, and in 1901, Danlos uses radium to treat skin cancer. And in 1905, Dr. Robert Abbey, he is an American surgeon. He did the first practical application of interstitial radium therapy. And in the 1950s, radium, as we know, was hazardous and it started getting replaced by safer isotopes like cesium-137 and iridium-192. And in 1970s, there was introduction of HDR brachytherapy. And in 1980s, imaging advances had happened that had improved precision in brachytherapy. In India, we should know the timeline of brachytherapy. In 1920s, the first documented use of brachytherapy was done in Kolkata. And in 1941, the first radon plant was established at TMH Mumbai. In 1981, the first manual after loading iridium-192 unit was installed at TMH. So here we can see on the right-hand side, what is a manual after loading machine that the person who is involved in treating is directly installing the sources onto the particular site where we want to treat. That is manual after loading. And then in the late 1980s, introduction of remote after loading brachytherapy happened. So here we can see the microselectron HDR brachytherapy machine, and we can see the system, the console, where the placing of the sources can be remotely controlled. And in the late 1990s, transition to HDR brachytherapy, which is high dose rate brachytherapy, happened across Indian centers. So this is the latest source that we use in brachytherapy, which is called the iridium-192 source, which has a half-life of 74 days. The source size is very small, like we can see here. The active length of the source is just 3.5 millimeter, and 1.1 millimeter diameter, and it emits gamma rays. There is a high specific activity for this brachytherapy source, and it is used for various gynecological, prostate, breast, and head and neck cancers. So here we can see that the iridium 192 source is attached to a steel cable, and that is there within the HDR microselectron machine, and that goes and treats the patient through the catheters that we install there. So let's see the steps also in detail, which will make this concept more clear. So there are various types of brachytherapy, and depending upon the placement method, they are divided into interstitial, intracavitary, intraluminal, and surface brachytherapy. So in interstitial brachytherapy, the radioactive sources are implanted directly into the tumor tissue. Like we can see that the catheters are placed directly on the tongue, as we can see in the figure that is given here. Intracavitary brachytherapy, the sources are placed inside the body cavity like the cervix or the uterus. In intraluminal brachytherapy, the sources are placed inside a hollow organ or lumen, which happens in esophagus, lung cancers, etc. And in surface brachytherapy or surface mold brachytherapy, the sources are applied directly to the surface of the skin. So in head and neck cancers, the most commonly used type of brachytherapy is interstitial and surface mold brachytherapy. And based on the dose rate, we have divided this into low dose rate, which is 0.4 to 2 gray per hour, intermediate dose rate, which is 2 to 12 gray per hour, and high dose rate, which is more than 12 gray per hour. So we can see, as I have already discussed in the history, that there was a transition from low to high dose rate. And in high dose rate, there are various advantages, which we can see in this table, mentioning the difference between a low dose and high dose rate brachytherapy. So in low dose, what happens is that there is a low continuous over hour to days treatment of the patient. But in high dose rate brachytherapy, it is just delivered in few minutes. And the treatment duration, as we know, is long in low dose rate. There is a requirement of hospitalization and stay during this procedure. And the brachytherapy in high dose rate is usually on an outpatient basis. So we insert the catheters, and then on a day-to-day basis, the patient can be even routinely called on an OPD basis and treated. And patient comfort is also more in high dose rate brachytherapy, where there is quick treatment happening. And radiation safety, what happens in low dose rate is that the patient can emit low doses of radiation. So that is important, that in high dose rate, there is no requirement of isolation, as the source is immediately removed after the session. So in brachytherapy for head and neck cancers, it can be used as a standalone therapy, where it is used for very early stage or smaller tumors, and sometimes where there is advanced disease. In certain cases, when there is the size of the tumor which is more than 4 centimeter, maybe we combine with external beam radiation therapy to treat the at-risk lymph nodal stations also. And as I already told, it can be used in the primary setting as well as the recurrent setting. And it provides high local tumor control with limited morbidity. And it is widely used in lip and early buccal cancers. So these are the IBS recommendations and guidelines for brachytherapy that was published recently. And we can see that in T1N0 disease, which is very early head and neck cancers, or mostly when we talk, we can think about either a lip or an early buccal cancer. We can either use it as a radical treatment or as a boost treatment. So radical treatment is when brachytherapy is the treatment of choice, and we deliver the whole treatment through brachytherapy alone. But sometimes when you have larger tumors, you start the patient on treatment with external beam radiation therapy, and then we give boost subsequently to the patient. So when you give the radiation therapy in radical setting, it will be about 2 weeks duration, and the treatment will be completed. But when you give it in the boost setting, normally you start with external beam radiation therapy. You give about 4 to 5 weeks of external beam radiation therapy, assess the response, assess the tumor control, shrink, etc. And then you plan for about 20 gray in 7 fractions, 21 gray 7 fractions, something like that as a boost dose. And it is also used in the re-radiation setting, but there you have to be very careful. The criteria for brachytherapy in the re-radiation setting also remains the same, whereas we tumors in lip or early buccal cancers, where it is favorable, you can consider for brachytherapy. This is an article that was published in the Red Journal on the long-term results with brachytherapy in lip cancers. So 172 patients were treated from 90 to 2008 at a center in France. And it was seen that the local control was 92.8% for skin carcinomas. So what they have done is divided the lip cancers into the mucous surface, the mucosal aspect of the lip, as well as the anterior aspect of the lip. So it was 92.8% for skin cancers and about 89.1% for mucosal cancer. So we can see that the local control rate is quite good when you give brachytherapy in early lip cancers, and a good relapse-free survival and overall survival. And the most important thing is that the cosmetic and functional outcomes were very good, and with 92% of the patients telling good cosmetic outcomes. So, is there still a place for brachytherapy in modern treatment of early stage oral cancers? So, as we know, there is excellent results that comes from lip cancers, and it is a very good treatment modality in the salvage setting, but it requires meticulous technique and also a close cooperation between the radiation oncologist, physicist, and the surgeon. So, in the joint clinic or the multidisciplinary tumor board, when when an early lip cancer or an early buccal cancer come, we evaluate, the radiation oncologist as well as the surgeon evaluates, see what is best for the patient, and if the cosmetic and functional outcomes are superior with giving brachytherapy to this particular patient, we should definitely have a discussion, talk to the patient, inform the patient, and then consider for the next best treatment option. So patient selection for brachytherapy is also critical. So ideal candidates are those who have localized small accessible tumors which are less than 4 centimeter, which is T1, T2, and node negative disease. The lesion should be away from the bony structures, and also the patients should have a good performance status. Like we know, anesthesia is required for brachytherapy, and that is why the patient should be medically operable before we consider a patient for brachytherapy also. And the contraindications are that those patients who have trismus, for example, if you have an early buccal cancer, but the patient has trismus or severe submucous fibrosis, it will be difficult for us to place the catheters. So those are contraindications. And also when the tumor is situated next to critical structures like bone or cartilage, so there is an incidence of osteoradionecrosis, which happens if the lesion is situated very close to the mandible and near the great vessels. Also, we should be very careful because it can lead to bleeding and then other problems. And also, if the even though the lesion is small, but if it is not very well accessible by brachytherapy, that also becomes a contraindication. For example, if you have an early buccal cancer, but but the tumor is lying on the posterior most aspect of the buccal mucosa or near to the RMT, it is not. It is known that brachytherapy is not going to be feasible in such areas, and it is not going to give good results. So target definition and the type of implant. So as we know, like I have already displayed in this picture, we have certain concepts called the gross tumor volume, the clinical tumor volume, which is shown in green, and the planning target volume. That is usually a standard for external beam radiation therapy, but it is slightly different for brachytherapy. Here in brachytherapy, again, we have the gross tumor volume, which is the gross disease that we can see based on clinical examination and imaging. And we should also give a margin for the microscopic spread of the tumor, which is about 0.5 to 1 centimeter. So it is not that, again, we treat the gross lesion alone. We have to give adequate margins. and call that as the clinical target volume and treat that area well and nicely. So the implant technique is also very critical because the geometry of the implant decides how good we can deliver the radiation doses. So precise implantation is critical, and we should see that the sources that we place or the catheters that we put are parallel and equidistant to each other to ensure better dose homogeneity. When we see the examples in the future slides, this will be more clear. So there is this JEC ISTRO recommendations for brachytherapy in head and neck cancers that was published in 2009 that gives various guidelines for subsites in head and neck. And to tell in summary, for example, in lip cancers, selection of tumors which is less than 5 centimeter. We know that 5 centimeter is more towards a T3 disease. But when we have a tumor which is involving the lip, which is 5 centimeter in size, but not involving any other surrounding structures, we can still consider this patient for an EBRT followed by boost. In EBRT, we treat the primary tumor as well as the neck nodal regions to about 50 gray in 25 fractions. And then, depending upon the response at the primary site, we boost so that we give a 70 gray equivalent to the gross disease. And as we know, when you have disease involving the bone or near to the bone, it is contraindicated. Local control is good. We should also think about necrosis that can happen in the long run. So in buccal mucosa, tumors that are less than 4 centimeter in size is usually considered with less than 1.5 centimeter thickness. And brachytherapy alone should be sufficient smaller tumors. And again, it could be combined with EBRT if needed for larger tumors. And if it is involving the buccoalveolar sulcus or the posterior aspect of the buccal mucosa, these are not usually preferred. In tongue, also brachytherapy has been practiced, but we don't routinely use brachytherapy in tongue because we know that tongue has got a rich lymphatic supply and there is a high chance of lymph nodal spread that happens. So brachytherapy alone for tongue cancers may cause nodal relapses later on in the neck, mostly in the level 2 or 1B regions. So that's why we should be very careful while treating patients with CA tongue for brachytherapy. So in our hospital, we don't usually treat tongue cancers with brachytherapy because of this reason of lymph nodal spread. And brachytherapy has also been practiced not only in oral cancers, it has also been practiced in oropharyngeal cancers. But as we know, these are not very easy techniques to perform, and it definitely requires expertise and a learning curve before we treat these patients with brachy. Later on, the JECISTO again updated their guidelines in 2017, in which they mentioned that imaging plays a critical role while we assess the tumors for brachytherapy. So, whenever required, we should use an MRI for a tumor extension, CT scan when you have suspicious bone invasion, and PET scan if it is required. So, we know that we don't routinely use PET scan in early stage tumors, but these are some of the recommendations that was given from the JECISTRO group. And here we can see that stepping source technique is used for brachytherapy. So, stepping source technique is what actually means by stepping source is that the source goes and treats in various predefined paths. So so from the machine, the source goes inside the catheters, treats a particular area, goes to the next dwell position, treat that, then goes to the next. So like that, there is a stepping source technique that happens in HDR brachytherapy. And as I already told, there is no concept of planning target volume that is in external beam radiation therapy. So clinical target volume is what we should be covering in brachytherapy, and implant geometry is critical for having the best outcomes and giving the best dose distribution. And dose calculation is also nowadays done based on 3D imaging. So once the implant is done, previously X-rays were used to see how the implant geometry is there and treat the patient. But nowadays, for each patient, CT scans are used, 3D reconstruction techniques are used, and then Paris system is the interstitial brachytherapy technique that is used, and that is followed for treating such tumors. And organ protection is also very important. So what happens is that sometimes when we treat lip tumors, the sources or the catheters may be in close contact with the mandible after the patient like is done with the procedure, once the edema settled down. So what we should specifically see while we treat is that we should give a gap between the mandible and the lip. So either we place a wax mold or a wet gauze in between, so that we can reduce the doses to the mandible as much as we can. So now I will describe a case capsule for a patient who has cancer of the lip, which is a T1N0M0 of the left lower lip. Pre-treatment assessment is critical. So accurate assessment of the tumor dimensions should be done by clinical examination as well as imaging. So in the lip, normally the patients come with a CT scan and we can assess the tumor size clinically. So clinical examination will definitely help us know the extent, induration, and any submucosal spread. And along with imaging, it will definitely help to identify if there are any neck nodes. And submucosal spread can be examined by clinical evaluation or EUA, and assessment of neck node involvement is critical. So if we have a doubt, we should get an ultrasound of the neck done, and if there is any suspicious node, that should be FNAC'd, and we should make sure that the node is negative before we proceed with brachytherapy. Like we know, brachytherapy is local treatment and it does not treat the neck nodes. So we should also rule out other lesions in the upper aerodigestive tract. So if a patient presents with cancer of the lip, we should also see that we do a proper examination of the oral cavity to see if there are any other synchronous lesions that are present. And feasibility of brachytherapy is very important. We should see the mouth opening, we should see the dental status, how is the, if there is any teeth which requires extraction, which is near to the implant site, we should make sure that a proper dental evaluation is done and the proximity of the bone to the implant site is determined, and any spacers, like I already told, should be used. And fitness for anesthesia also has to be seen. And in TMH, we have a brachytherapy checklist when we see the patients and initially evaluate the patient. So the patient is assessed by the consultant first for suitability for brachytherapy. We always take clinical photographs of the patient before we take the patient for treatment, because we need to see how the lesion has responded over time and how well the treatment has happened. So definitely for all patients, we take a clinical photograph and then we counsel the patient, because patients may know more about surgery and excision of the tumor. So we have to make sure that we counsel the patient, we tell them what we are going to do, what are the expected outcomes, what are the risks or benefit, what are the toxicities, costs, etc. that is involved in this procedure. Pre-anesthetic evaluation has to be seen. Neck imaging, like I told, even if we have sometimes a CT scan available with us, if you find any node that is suspicious, it has to be definitely FNAC'd and seen that it is negative before we proceed with treatment. Dental prophylaxis is also very important. And we should also get recent blood investigations and viral markers, etc. So, patients for brachytherapy requires general anesthesia because of the complex anatomy of head and neck, and we should see that the radioactive sources are placed uh, with precision and with use of advanced imaging modalities. So imaging is mainly in the pre-treatment setting. So common technique that is used, we place the catheters in and around the tumor for source delivery, and there is continuous monitoring which has to be done during the procedure to ensure accurate delivery and minimize complications. So these are various instruments that we use for brachytherapy procedure. We can see various colored beads and buttons that are used where we initially insert and then we replaced it with nylon catheters. And we can see in this particular patient what is happening. So the patient with CA lip T1N0, we do after general anesthesia parts preparation, we assess the tumor again, and then we mark the tumor border. So that we have to give adequate margins to the tumor, and needles are inserted. Subsequently, needles are inserted, and there are two planes where we normally insert the needles. So one is the submucosal plane and one is the subcutaneous plane. So here we can see the needles that are being inserted in the first in the submucosal plane, which is the deep plane, and subcutaneous plane, which is the superficial plane. So once the needles are inserted, flexible catheters are introduced through the needles. The needles are pulled out. The buttons are placed, followed by placement of different colors of beads. So why we place different colors of beads is that when we evaluate the patient later on during the planning, we have to know which is the superficial plane and which is the deep plane. So normally what we do is we give a particular set of colors for the superficial plane and a different set of colors for the deep plane so that we know which is which. And numbering is done in a systematic order, which is done from left to right and deep to superficial. So this is how the catheters are placed in the operating theater. And the next case is of a buccal mucosa, which is again a T1N0M0 lesion. And here we can see that markers are placed. So initially, we have to see, assess the tumor, and then mark the tumor borders, and again give adequate margins, which we call as the clinical tumor volume. So we mark the tumor borders, and then we again draw through which areas we are going to implant these needles, so that we can see here in the second image that we draw, and then see that the sources are parallel and equidistant to each other, and the two plane or implant geometry is maintained. So we can see the first needle being inserted in the submucosal plane here. So in this patient, a total of 4 needles were inserted parallelly first in the submucosal plane. So how we ensure which is the submucosal plane and subcutaneous plane is that during the process of insertion, we keep one of our fingers inside the buccal mucosa, for example, in this patient, and we should make sure that first of all, the needle is maintaining that geometry, going straight, going parallelly to the next needle, and we can also feel the needle through our fingers that is inside the mouth, and slowly advance it so that it doesn't pierce or come out anywhere, and then it goes straight, and we can take it out from the other side, as you can see in this picture. So for this patient, we inserted 4 needles in the submucosal plane, and in the superficial plane, the subcutaneous plane that insert needles, maintaining a triangular geometry. So again, in cutaneous, we need to see that we are inserting the needle very superficially. So here we touch on the surface of the skin and see that the cutaneous plane is very close, not extremely close to the skin, but it should be close to the skin so that we know that a good geometry is maintained and there is good gap between the subcutaneous and the submucosal plane. So for this patient, a total of 7 needles are inserted, and subsequently the treatment is delivered. So in head and neck cancers, depending upon the location, mostly we do 2 plane implants, which are the and mostly about 6 to 8 needles that we usually require for a case of cancer of the lip or buccal mucosa. So once the catheters are introduced, the needles are taken out, beads of different colors are inserted in different planes and numbered, and numbering is done as a whole in a schematic manner, and the patient is shifted for recovery for further imaging and planning. So, a comparison of brachytherapy versus surgery for treatment of stage 1 to 2 squamous cell carcinoma of the tongue, like we already know, there is no one evidence that we have in this setting. So, most of the studies that we have are prospective studies, which may be single arm studies. In this study, what they could see is that patients were divided as per, we can see LDR, which I already described, HDR, and surgery. The rate of neck failure, that is the matter of concern when we treat patients of tongue cancers with brachytherapy. So, because of the rich lymphatic supply, we should always keep in mind that such patients may have no later on no for any local treatment that we do. So in this paper, it was seen that with surgery, the neck nodal failures were much less as compared to brachytherapy. So once we are done with implant and patient for CT scanning. So once the patient goes, again, the physicist helps us in identifying where the source has to be placed and what is the length of the tube that we have used for the patient, and catheter measurements are done and CT cuts are taken. So this is the treatment planning system. I am not going into the details of the physics in planning, and we have on-centra brachytherapy systems that is used exclusively uh, treat for treatment planning in brachytherapy patients. And once we see that the dose distributions are good and the implant geometry is fine, we proceed with prescribing doses and then plan for treatment. So this is how the treatment execution is done. Here, this is like the HDR mesh we have such kind of why catheters that are placed on the patient. Here we can see those are numbered and those are connected to these wires, and that is connected to the machine. So this is a review article that I have written from in brachytherapy. And Indian clinicians, as we know, are pioneered in brachytherapy techniques. So in India, we used to do a lot of brachytherapy for tongue using techniques like loop technique for cancer of the tongue. And there are also various other techniques like submandibular gland transfers and then using interstitial therapy so as we can reduce the doses to the salivary glands. And also we have done therapy in various uncommon sites like external auditory canal, also epiglottic. So coming to surface mold brachytherapy. So surface mold brachytherapy is a different concept. It is now is brachytherapy. The other form of head and neck brachytherapy that used is the surface mold. So this is a type of radiation therapy where the radioactive sources are placed on surface of the body using a custom-made mold that conforms to the shape of the treatment area. It delivers high dose radiation, targeted radiation with minimal impact on the surrounding tissues. So why surface mold? Which tumors can we target? So again, these should be accessible site, very superficial tumors having well circumscribed margins without any regional or distant metastasis. The extent of the tumor should be such that we will be able to apply a mold, and tumors lying over the surfaces which are either flat or not greater curves than semi-cylinders or hemispheres. These are important so that we can use our surface mold brachytherapy well and adequately to treat the patient. So normally what we see in clinic at times, we see a basal cell carcinoma of the nose or the ear, where we again have to counsel the patient about the possible treatment options. And in such situations, surface mold brachytherapy is used which has also shown excellent results. So we will discuss a little bit in detail about surface mold. So we know surface mold, again, it's a simple procedure, doesn't require any anesthesia. These are placed like this on the surface of the patient. Short duration treatment, non-invasive, cost is minimal. We can achieve homogeneous dose distributions with good clinical outcomes. But these are used only for treating very superficial, well-subscribed, accessible skin tumors or early hard palate lesions. So I'll just tell the steps in using a surface mold brachytherapy technique in basal cell carcinoma of the nose. So here we can see an elderly lady having a BCC of the nose. We have delineated the tumor and also given some margins. So here we can see that we have to use certain, we have to give some margin so as we can fit the custom mold for the surface mold brachytherapy well. So here we have to prepare a negative cast with a dental acrylic material positive cast. So here we can see how a positive cast is made, and then once this is made, it is removed from the surface of the patient, and this is how the mold looks like. Then we again mark the tumor on the surface of the mold and also the margins that we should use for placing the mold, and acrylic material is used. We again place this on the mold, and then we insert the catheters. So insertion of the catheters is done on wax here. Like we can see, a small wax bolus is being used. The catheters are inserted through this wax bolus that is made, and we can again see that we maintain the geometry which is parallel and equidistant to each other. And this is how finally the mold will look like, and the patient will be treated with this form of brachytherapy. Surface mold is also used in CA hard palate. So this is a case which has been done similarly, where we can see a negative cast is made, a positive cast is made, a mold is made subsequently, and then the patient is treated with surface mold brachytherapy. So once the implant or the surface mold is placed again, we again take the CT cuts, see how the catheters are placed, how well the geometry is there, and then we see the dose distributions, and then we treat the patient with surface brachytherapy. Another patient with surface mold for external ear, we can see similar steps and how and the tumor is marked, placed, and subsequent treatment execution is done. So here we can see the patient post-treatment on follow-up has responded excellently to the treatment, and then the patient is on active follow-up without any complaints. So from our institute, we have also published clinical outcomes with high dose rate surface mold brachytherapy for intraoral and skin malignancies. So 35 patients with T1 to T2 N0 head and neck tumors were studied. Superficial tumors over sites like hard palate, hard soft palate junction, or over the skin like cheek, nose, and ear was taken. HDR brachytherapy was used using customized surface molds. So in the radical setting, as we know, we give about 52 gray in 13 fractions equivalent. And in the boost, we give about 20 gray equivalent after EBRT. So the local control rates, the 5-year local control rates were excellent, 92% for skin tumors and 76% for intraoral tumors, and with minimal toxicities, excellent cosmetic and functional outcomes. So these are the doses for brachytherapy, like I already mentioned in some of my previous slides. So in radical brachytherapy, we give about 52 gray in around 13 fractions. So this is 4 gray per fractions. So how we normally treat is that we give 2 fractions in a day. So 2 fractions should be at least 6 hours apart. So once the patient is taken for the procedure, once the procedure finishes, patient goes for CT scan. Sometimes we take the CT scan on the same day, or sometimes for the edema to settle down, especially in lip cancers, we take the CT cuts on the next day also. So once the CT scan is done, we plan the patient and then we start the treatment on the same day itself. And this will be, if it is about 13 fractions or 12 fractions, we can complete the treatment in about 2 weeks duration. So we treat from Monday to Saturday two times, which is separated by a 6 hourly gap. And in boost brachytherapy, we give about 45 to 50 gray EBRT, external beam radiation therapy, followed by about 3 gray into 7 fractions of interstitial brachytherapy. So coming to another paper that was published again from our institute, that was on intensity modulated radiation therapy alone versus IMRT and brachytherapy for early stage oropharyngeal cancers. It was a phase 3 randomized control trial, and we divided patients into IMRT alone versus IMRT plus brachytherapy for early stage T1 to T2 oropharyngeal cancers. The number of patients were 200, 100 in each arm. IMRT alone given one arm. So what we did is a total dose of 50 gray in 25 fractions was administered to the primary as well as to the neck nodal region. So here we know this is an oropharyngeal cancer. We have to give elective doses to the neck. So that's why in the initial setting, we treat the primary tumor as well as the nodes to a dose of 50 gray in 25 fractions, and following this EBRT, we assess the patient again and then plan for brachytherapy. So that is what I was talking about, boost brachytherapy. So here in the IMRT alone arm, patient will be given 20 gray in 10 fractions IMRT, which is 70 gray equivalent. So the patient will receive a 70 gray equivalent treatment dose in the IMRT arm. And in the brachytherapy boost arm, after 50 in 25 fractions, we again assess the patient, we implant the patient, and then we give a boost dose of about 21 gray in 7 fractions. And the primary objective was to see reduction in xerostomia by salivary scintigraphy at 6 months. And the secondary objectives were local control, progression-free survival, and overall survival. So here, as we can see in the graph also, that IMRT and brachytherapy arm, the incidence of xerostomia at 6 months was 14% as compared to IMRT alone arm, which was 44%, which was statistically significant. So we could see a significant improvement in salivary function with the addition of brachytherapy. And for local control, we could see that the 3-year local control rates were not statistically significant. It was about 66.2% in the IMRT plus brachy arm and about 56.4% in the IMRT alone arm. And the acute toxicities were higher in the IMRT and brachytherapy arm, and the late toxicities, especially xerostomia, was lower in the brachytherapy arm. Re-radiation with brachytherapy is also feasible in recurrent head and neck cancers after we previously treat the patient with some form of radiation therapy. And it provides a good option for localized control of recurrence. So the doses are usually, when we plan for brachytherapy, we have to keep in mind what was the doses that was received in the previous treatment. We need to see that we have to minimize the risk of complications. But for example, if you have a tumor which is again happening in the lip, which is a small T1 tumor, we can still consider the patient for brachytherapy with good doses and treat the patient. And post-treatment care is also very important. So once we complete the treatment, we have to remove the catheters. So the catheter removal also, we do it in the operating theater with all the facilities, and we make sure that the patient is not bleeding and post-treatment instructions are followed. So we tell the patient, once the patient is shifted to ward, they have to slowly start taking feeds, and once they start taking oral sips of water and soft diet, then we remove the nasogastric tube, and then we subsequently discharge the patient. So normally after brachytherapy procedure, after the treatment completion, mostly the next day the patient is fit and fine to be discharged from the ward. And the side effects, we know that brachytherapy is a local treatment, and in cancers of the uh, buccal mucosa or the lip, we see that there is a incidence of mucositis that happens. So there will be some mucositis which will be there during the time of treatment, and also following treatment, the mucositis is likely to increase. So we need to counsel the patient adequately, tell them what are the possible side effects that can happen, review the patient. So mostly how we do is we call the patient next week again for a toxicity assessment, and then subsequently at 6 weeks to assess if the patient is fine and the tumor is well responded. And also we see certain long-term issues including hypopigmentation and some induration at the implant site. So, the take home message from this uh, seminar or lecture on brachytherapy is that brachytherapy provides high dose localized radiation surrounding healthy tissues are spared. Ideal patient selection is crucial for considering a patient for brachytherapy. It definitely requires a multidisciplinary evaluation with a surgeon as well as a radiation oncologist. It definitely requires expertise and there is a learning curve, especially in sites like oropharyngeal cancers. It is effective in treating small, well defined, and accessible tumors when the tumors are larger in size and node negative. It is combined with external beam radiation therapy. Use of HDR and remote afterloading systems have improved precision. It can reduce toxicities in the long run, including xerostomia, like we saw for oropharyngeal cancers, and also improve the quality of life. High local control rates are achieved, and it is also important to know that the cosmetic and functional outcomes are excellent with use of brachytherapy in early oral cancers. Thank you. And this is a patient that we treated in ACTRIC recently. She presented with a carcinoma of the lip, which was nearly a T2 N0 lesion. We had assessed the patient. The patient was node negative. We had done brachytherapy, and this was a 7 needle 2 plane placement. And this is how the patient has come to us after 3 months of treatment with brachytherapy. Thank you. If there are any questions, I'm happy to answer.
Thank you, Anuj. It was a wonderful class. I think there are questions in the chat box. I will read to you. One is, suppose we get a less than 2 centimeter lip tumor involving the commissure, and patient is very much concerned about the aesthetics. So will brachytherapy help in preserving the commissure in such cases?
Yeah, so here that the lesion is less than 2 centimeter. So definitely in such cases, we know if we subject the patient to surgery, the cosmetic results will be definitely compromised. So in such situations, in lip, especially uh, when there is a likely involvement of the commissure, brachytherapy is definitely a good treatment option. And in such situations, so when you have lesions which are approaching the angle of mouth or the commissure, like you have already told here, it is always better that with brachytherapy, the cosmetic outcome as well as the control is going to be excellent. And just we have to make sure that the patient is node negative. And if the patient is node negative, brachytherapy alone, like I told, if you give a good 52 gray in 13 fractions, that should be sufficient for an excellent local control.
So I think Anuj, it will be not only the aesthetic control, it will be better functional control also. Because whenever
Yes,
we are
yes,
going
yes.
to
Yeah.
remove commissure, there is going to be some sort of decreased mouth opening as well as some sort of drooling can happen later on. So I think this will help
Okay.
with that also. You agree with that, Anuj? I think that should be
Yes,
the
yes.
yes. So
Yeah,
can
so
you?
definitely. So, yeah, cosmetic functional outcomes as well as control. So, combination of three will be definitely higher for brachytherapy. Exactly what you told me.
Yeah, only thing that you have to look for the neck nodes, which you already presented in
Yes,
your
yes, yes, yes.
lecture. That has to be taken
Yes,
care of. So, can you
yes.
explain positive and negative mold again?
Okay, okay. So like I have 1 second. I will just go to my slides. So this was the case I was describing to you. So here we can see that this patient, if we have to do a surface mold, we have to make sure that we place a customized mold for the patient, which is comfortable for the patient. So for nose, you have to make sure that the patient's area, the area which is surrounding the nose, as well as the region till the forehead, is covered adequately so that the mold, first of all, doesn't move. So we secure the mold with good straps and see that the patient is not the mold that we place is completely immobile and it is not affecting the treatment in any way. So here, while we do this in that procedure, we have to see that we prepare a mold with a negative cast as well as a positive cast and then make the impression. So here we can see that certain dental materials are used for making a negative cast. So here, once the negative cast is made, so once the patient lies down, we place a gauze or or a small layer of a pad, and then we uh, prepare this material on the surface of the patient, and then we again have to make, so this material will be around about a plaster of Paris material will be used as a positive cast. And here we can see in this fourth image how the negative mold is being prepared, and then on top of that a positive cast is being made. So here we can see the impression. So if you see the third picture, you can see exactly after making this how the mold is appearing. So here we can see the two layers that have formed, so that we can actually delineate the tumor very well. So here, once the cast is made, so first layer and the second layer, then we take it out, then we again, the inside of the cast is again placed with this particular positive or the plaster of Paris cast, and then we get an impression like this. So here we can see how well the impression is made after we prepare a negative cast as well as a positive cast, so as to get the exact tumor dimensions. So, what we can see is once this positive cast is made, we use acrylic. So, here we can see a small layer of acrylic material that is placed on top of this cast, which has to be subsequently placed on the patient. So, first, when you do a negative cast, then a positive cast, then you mark the tumor on that, and then you place an acrylic or a wax bolus on that. It will make sure that our tumor is not actually losing out on any of the conformity that is going to that we have to make sure during the treatment procedure or the process of entire treatment duration. So what normally happens is that if you don't make the cast well, there can be some gaps that will be happening between the surface of the patient as well as the mold that we have made. So if you don't make this cast well, the gap can actually cause differences in those distributions that is happening there. So that is why this whole procedure has to be done in a very good manner, in a systematic manner, so as to uh, have the best results that we can. Okay, so I hope that is clear, the steps in making a cast.
Uh, Another question, is brachytherapy useful in buccal cancers which involve the skin?
Useful in buccal mucosa cancers involving the
Cancers
skin. So here
involving the
again, yeah, so here again, what happens usually is that when you have lesions involving the skin, as per our AJCC staging, it has become a T4 tumor. So ideally, if there is involvement of the skin, normally we will have to consider the patient for surgery. But if it is just involving the angle of the mouth, we can still consider the patient for brachytherapy. So that is why it is very crucial to select the correct patient for brachytherapy. So skin lesion, skin definitely, we know that it is a T4 disease, and achieving tumor control just with brachytherapy may not be feasible in such a situation. So then we will have to give a combined modality treatment, which can be surgery followed by adjuvant treatment.
Yes, I agree, Anuj. So for buccal mucosa cancers which are involving the skin, surgery is the way to go. You don't have to do brachytherapy for them. Then the next question is functional outcome is better with brachy as per your presentation. However, you find it in the other way around as patients can't do jaw stretches or neck movements as the catheter may get dislodged. What is your take on that?
So once you do the procedure during the process, so you told that the patient can't do jaw stretches. We know that during the procedure, or not during the procedure, during the course of treatment, the patient should be relaxed as much as possible. That time, it is not feasible to do exercises because we know that the catheters are should maintain the geometry, and that is utmost important requirement when we give the patient treatment with brachytherapy. But we know, like I already told, these are short course treatments. So if you subject a patient for brachytherapy, we will just require about 2 weeks of duration for completing the entire course. So that is why during that course of treatment, like you told, I agree that we won't be able to do any exercises during that course of treatment. But as soon as the treatment completes, as soon as the reactions settle down, the patient should be able to undergo exercises.
Another question, for hard palate surface mold brachytherapy, is proximity to bone a concern?
Hard palate, yeah, definitely. So here, first we have to see for a hard palate lesion is that we need to get a CT imaging done. We need to see how superficial the tumor is, how close it is to the bone, and if it is close to the bone, again we have to make sure close to the bone. We have to make sure whether there is any involvement or not. So if there is no bone involvement, it is very superficial on the hard palate T1 lesion, we can definitely consider for brachytherapy. But if these are infiltrating tumors and if it is very close to the bone, like I already told, it is better to consider the patient for surgery followed by adjuvant treatment.
So last question, Anuj, is there any input on cancers which involve the eyelid? Your experience or
Yes.
literature, what does it say?
Yes, yes. So we have treated many patients with eyelid who has eyelid SCC. So there are patients who have come to us with squamous cell carcinoma of the eyelid, and in this situation also the same principles are followed. So we assess the patient, and then we have treated few patients recently. Also, we treated a patient at Actrec who had an eyelid squamous cell carcinoma. And in such situations, we have to be very sure that our implant is very precise and it is done very meticulously. Like normally, when we have eyelid cases, like I told you here, we use about 7 needles or 8 needles for oral cancers. But in eyelid, we use just about 2 or 3 tubes should be enough when you do an eyelid brachytherapy. But it has to be very meticulously done, and the outcomes are also very good with brachytherapy. So we have to see that again we are using conformers. We have to avoid the eye or the cornea getting radiated. So that's why we use again spacers to avoid any doses that goes to the eye, and then you can treat the patient. So eyelid definitely is a good like case in specific situations for brachytherapy where we can again uh, uh, reduce the event of having a major morbid surgery.
So, Anuj, one last question from my side. Like, what
Hmm.
histologies do you treat for skin and eyelid and lips? So, we know that
Okay,
squamous
okay.
carcinoma we are talking
Yeah,
about, but what other
yeah.
histologies you can treat for the sake of discussion and for the
Okay,
juniors? So, if
okay,
you could.
okay. Yeah.
Hmm.
Yeah, yeah. So for skin, mostly what we see is basal cell carcinoma. So basal cell carcinomas of the skin can be treated with radiation therapy. So it is not that always we treat with brachytherapy itself. So these are superficial tumors, and those can also be treated with radiation therapy, which is external beam radiation therapy, or specifically we can use electrons for treating such patients. So when we talk about histologies, we normally can consider for radiation therapy with good results in BCCs, sometimes basosquamous cancers, and squamous cell cancers. And these are the histologies. As much as we go for other aggressive histologies, it is not ideal that radiation therapy may be a very good treatment option. Also, in the lid, what we have seen and the few cases that we have treated was squamous cancer. And even in the oral cavity or within the oral cavity, it is the squamous cell cancers that we treat. So normally when we treat the patient for with radiation therapy also, it is always important that we have the diagnosis of an invasive squamous cancer, because many times we may come across an early tumor of the lip which may be still coming as a very severe dysplasia. In such situations, it is not recommended to use brachytherapy, because first of all we don't know what is the histology, whether it is invasive. Then using such a modality is not very justifiable in such a situation. So to be short, for skin cancers, we normally treat, we see a lot of patients who come with basal cell carcinoma, squamous cell carcinoma, that is routinely treated in daily clinics.
So, with this, I thank you once again, Dr. Anuj, for such a wonderful lecture, and we conclude today's class. Thank you so much.
Thank you. Thanks a lot.